Good morning. I'm Jim Taylor. I'm President and CEO of Voices of Alzheimer's. I'm really very happy to be with you this morning to explore an important and very timely topic. It's a special day for me because I'm sitting in the Jerry Taylor Conference Room in Orlando, Florida, at the Charter Research Organization, who doubled their space yesterday and had a ribbon cutting ceremony with over 400 people here. And they dedicated this beautiful conference room to my late wife, Jerry, who died on August 4th after 12 years of living with the disease. So it's quite a remarkable attribution to Jerry and the work that she accomplished as an Alzheimer's advocate. And so I'm really very grateful to Charter and want to extend a special thank you to them. We really got a very exciting event this morning, and I really appreciate your joining. First, a little, if you're not familiar with Voices of Alzheimer's, let me tell you just a little bit. We were launched just 2 years ago, and our mission is to empower individuals living with or at risk of Alzheimer's and other cognitive illnesses to unite these individuals around the urgent need for equitable access to innovations in treatment and care, while fostering a society that honors their voices and choices in managing their health and well-being. First, address a few housekeeping issues. We will have 15 or 20 minutes of questions after our presentation and discussion with the panel. So feel free during the panel discussion to enter your questions into the chat function, which is at the bottom of your window, bottom of your screen. And if you have any problems, send a message through the chat function to Kim, who's our host, and she'll try to help you with any technical or with your questions. We'll be recording this session and putting it on our website, voicesofad.com. If you want to share it with your friends or listen to any parts of it again, you'll be able to find it there. If you're not a member of Voices of Alzheimer's, we would really like you to do that. And you can also do that on our website, voicesofad.com. Now to the program. Today, we're talking about Alzheimer's blood tests. You may have heard about this topic previously, but we really want to share from two knowledgeable individuals more about this exciting breakthrough in the diagnosis opportunities for Alzheimer's and what that advancement will do for potential patients, care partners, clinicians, and advocates. I'm going to let the panelists introduce themselves to you. We're joined this morning by Dr. Michael Hornbecker, who is a U.S. Fellow Lead at the Alzheimer's Collaborative Healthcare Systems Preparedness Program. Boy, say that fast, Mike. And Dr. Kevin Kelleher, who's much more simply a primary care physician at the Executive Healthcare System. These are not only outstanding general practitioners, these are remarkable human beings. And we are really very, very fortunate to have them with us this morning. Dr. Hornbecker, would you introduce yourself first?
Sure. Thank you, Jim, for having me, and good morning to everybody. My name is Dr. Michael Hornbecker. I am formerly a practicing primary care physician for about 13 years. And in June of this year, I joined the Davos Alzheimer's Collaborative as the lead of their U.S. fellowship program, where we will be seeking to start early detection programs in primary care across the United States and add on to our tool that we currently have called the Blueprint for Early Detection Programs, which is a free and open access website where people can explore resources to start early detection programs in primary care.
Dr. Kelleher. Thank you, Michael.
Thank you. Good morning. Thanks for having me here. So I'm a family physician. I'm born and raised in Buffalo, New York. I always like to get that in. Go Bills. So for 30 years, I've been practicing a family physician, full spectrum. The last 20 years, I've been in a sort of a membership practice that has allowed me more time. And so I get to understand my patients a little bit better. And then the last 2 years, I've kind of put a focus as I've become an older practicing physician on kind of longevity and wellness, which to me focuses on cardiovascular disease, cancer prevention, and dementia prevention. And then I had the pleasure of being introduced a year ago to both Jim and Jerry. And again, Jim, sorry for your loss, but a wonderful, powerful couple who are advocating for this disease and earlier detection and prevention and treatment. And so that's why I've been brought in here, as it's paralleled with what I'm hoping to do for my patients, as well as what this country needs to be advocating for its people.
Thank you, Dr. Kelleher, and please excuse me if I slip into usage of first names. No disrespect whatsoever. It's just a force of habit and friendship and regard. So before we jump into our topic, it just occurred to me that perhaps a little background would be helpful for our viewers. And we are in a new era, in my estimation, a new horizon for not just Alzheimer's, but other related cognitive illnesses, in that we now have 2 approved medications for treatment of Alzheimer's for early stage patients. And it's really changing the playing field, and there are many more exciting medications in test. In the United States, we have some 30, maybe 20,000 specialists, neurologists and gerontologists who can prescribe these medications, or who currently prescribe these medications. We already have up to 1 year or more waiting time to get a new appointment with these specialists. We have over 500,000 general practitioners, PCPs, in the US. So it's going to be really imperative that we provide the support and education necessary for the PCP community, the general practitioners, the family physicians, to be able to better diagnose, detect, and hopefully treat cognitive impairment, because our specialists are going to soon be overwhelmed as these treatments become more everyday accessible, and hopefully even further new generations of drugs being developed. So what we're diving into today is the diagnostic opportunities of, at least the diagnostic opportunities of a blood test, a blood biomarker. So we're just going to jump in and kind of introduce this area to you. And Dr. Hornbecker, maybe you can start by explaining exactly what blood tests are, Alzheimer's blood tests, and how they can help inform our understanding of the diagnosis.
Sure. So Alzheimer's blood tests or blood-based biomarkers are just that. They're simple blood tests. I think any patient in a primary care practice is used to getting blood drawn, normally on at least an annual basis, to check things like cholesterol or for your male patients, PSA, things like that. And these would be very similar in the way that they're drawn. You just draw some blood and send it off to a lab for analysis. The way that they help us to inform about Alzheimer's disease, we know when we're diagnosing Alzheimer's disease and treating it with these new treatments, we're really looking for the presence of amyloid, which is a protein that gets embedded in brain tissue and contributes to the disease. And these blood tests are ways to measure amyloid in the bloodstream, which correlates to the amyloid plaques that can be in the brain. So some of them measure amyloid directly, and some measure it sort of indirectly, or sort of a surrogate for amyloid. But that's what they're really seeking to detect when we're drawing blood to look for evidence of Alzheimer's disease in a blood test.
So, Mike, how are these different from the traditional diagnostic techniques?
So traditionally, I would say in primary care practices, traditionally, if you diagnose at all, it would be very clinical. So it would be based upon an assessment that is not based upon blood tests at all. There may be some imaging, but really it's a clinical diagnosis. A little more contemporarily, when we're diagnosing Alzheimer's disease, usually in the specialty realm, it would be with one of 2 tests, a PET scan, which detects the amyloid protein, or a CSF, which is cerebrospinal fluid assay, which we derive by doing what is commonly called a spinal tap, or what we would call in primary care or in medicine a lumbar puncture. Both of those tests are more expensive. Certainly the lumbar puncture is much more invasive than a blood test. So the blood test really affords us some convenience and a much less invasive way to gauge the presence of Alzheimer's pathology.
I noticed that phrase, if they're detected at all. What are you referring to in that regard?
So if they're detected at all, as far as the
general practitioner often does not.
Oh, yes. So I think most general practitioners, in my opinion, probably have a little bit of discomfort around the diagnosis of dementia. It's a difficult diagnosis to make. It's a time-consuming diagnosis to make. And when you're doing it clinically, you're very rarely are you doing it with a whole lot of confidence. I think most primary care docs still refer on to a specialist to confirm the diagnosis and of course then to decide on any treatment.
So I'm setting you up there a little,
Yeah.
Dr. Kelleher.
Yeah.
How familiar are primary care physicians with these tests, and what kind of training and information will they need to be able to implement them efficiently?
Well, we are not very familiar with these types of tests. And I think that is why there really has been a concerted effort amongst the medical organizations. I'm a family physician. I belong to an organization called the American Academy of Family Physicians. And they've really spent the last year trying to roll out educational information, things that all physicians need to do, called continuing medical education. We have to accumulate so many hours of credits every year. There's been definitely an effort to get that out there in front of us, to be able to research, to be able to understand it, to be able to see where we might be able to do additional testing. Honestly, even just the beginning of screening to get comfortable with it. I think, as Dr. Hornbecker says, family doctors and internal medicine doctors around the country, we don't have a depth of training on the nuances of natural memory loss and aging versus cognitive impairment versus dementia. And yet our population is aging, more and more, and we're encountering it more and more. So the simple answer is I don't believe we are that familiar with testing. What is good is there definitely is a concerted efforts. Organizations such as yours and even a video such as this is an opportunity to get information out, because it has to be in the hands of the people to encourage their primary care doctor to know more and to learn more. But I would say in the last 3 to 4 years, there has been a wave of effort to educate us. And then the question is, how comfortable can we get in diagnosing, screening, and making recommendations for treatment?
I'd like to give a special shout out to AAFP, the American Academy of Family Practitioners, of which you're one of 130,000 U.S. members. So the reach of this organization is tremendous throughout the nation, and they have made a priority of brain health and encouraging their members to be more engaged in brain health. And that's a tremendous step forward for all of us in the Alzheimer's and cognitive impairment community. So a real great thank you to them. Dr. Hornbecker, how might these blood tests improve early diagnosis of Alzheimer's in the primary care setting?
I think they have the potential to both speed up the process as well as to allow the primary care physician to make a diagnosis with more confidence. I think that to sum it up sort of quickly.
And why is speeding it up important?
Well, I mean, I think you touched on this a little bit at the beginning when you were talking about these new treatments. These disease-modifying therapies or anti-amyloid antibodies that are now available. It is very important that we identify patients early in the process, because these drugs do not have benefit when dementia has progressed to moderate or severe stages. So it's very important Hence our work at the Davos Alzheimer's Collaborative with early detection so that we can find these patients and get them the treatment that they need when they need it, so we can slow down the progression of disease.
I'm going to go to a first name basis, otherwise I'm going to get this all confused. So Kevin, what are the current challenges in diagnosing cognitive impact or Alzheimer's at a primary care level? And how can the blood tests help address these challenges?
So the challenges, I think, in particular for dementia screening even is, of course, time. Primary care offices are, as anyone on this call who has a doctor and sees them understands, difficulty getting in, difficulty getting time in front of your physician or clinician. And then the ability to screen for all the requirements and recommendations, as well as sort of treat the conditions that the person has in front of them. So time will need to be figured out. I guess what I, as a family doc for almost 30 years, what helps the doctor be better with their time management are protocols and algorithms, things where other experts have said, here is a standard way of looking at this. How do you interview your patient? How do you ask the questions? And that get validated by, I know if I follow these guidelines, then I'm going to be able to get to an accurate diagnosis in a more timely manner. And I think that's sort of one of my goals of this involvement, is to figure out who the people are out there to help us establish these criteria or algorithms, so that when I'm in front of a patient, I can take the time with them and perhaps their loved one to talk about the things we're looking for, to get a better in-depth understanding, to possibly have handouts and guidelines I give them in advance, so that when I see them again in 4 weeks or 6 weeks, we have even more data to evaluate. A lot of the differences and nuances of natural aging and memory loss versus dementia does evolve over time, and a primary care doctor is the most well situated to spend time over time with their patient. And so my hope is that's one of the goals of all these efforts, is we get some guidelines on what to be measuring, how to follow up with our patients in a 4 or 6 or 8 week time period, where we can then sit back down. So then I have the data to decide whether I should be evaluating more deeply for dementia. And Jim, as you know, I'm a big fan of, there's some reversible causes of dementia. Those should be investigated: nutritional deficiencies, thyroid abnormalities. And a family doctor or a primary care doc is perfectly situated to evaluate and rule those out. We've learned just this last year the impact of dementia, of just hearing impairment and vision impairment playing a big role in dementia. These are the perfect place for your primary care doctor to help you understand, are there other things going on that maybe are contributing to your memory loss? And then, to the point today, is, can I then have a tool if I'm on the fence of my diagnosis, or if I think we're getting close to the point of a diagnosis that dementia or early cognitive impairment is present, can there be a simple tool that can guide me in my next step? And I think, we'll spend a little more time on that, but from some studies, the best doctors spending time doing questionnaires. There are measurement questionnaires, we might get into them, like the Montreal cognitive assessment test, where a doctor can talk you through questions. But if I have a tool that can move my likely predictive skill of 50 or 60% accuracy up to 90%, which some of the evidence on these biologic tests are showing, that is just a game changer. There's not a lot of things a family doctor can diagnose with 90% accuracy right off, right off the bat. So that's where I'm very optimistic about where we are right now.
So you said you need guidelines. Are they there today?
There's guidelines and evidence on how we should interact with our patients to talk about their dementia. There's recommendations for what we should consider looking at, but there is not a guideline, even from the one main national organization called the United States Preventive Task Service, if I get that correct. I'm sure they'll correct it in the chat, but that's sort of what a lot of clinicians rely on, is saying, okay, this has been validated, there's a reason for me to do it, and by the way, now insurances will reimburse me for doing it. And currently there is not a recommendation to screen, which, as you know, I believe is a disservice to all of us as we're aging. And so that's what I'm hoping for, is an actual guideline saying it there is evidence to show we should be doing this, and that will support us better in our efforts.
So Mike, at DAC, are you concerned about the lack of guidelines that will sufficiently inform general practitioners on how to use these tests? And are we able to provide those guidelines?
The answer is yes, I'm certainly concerned. And as a, practicing primary care physician in the past, I was concerned about that. The USPSTF, not only do the physicians out there follow the recommendations, but reimbursement generally follows it as well. So, if we can get recommendations and guidelines from the USPSTF, it will give physicians the impetus to make time to do those screenings and to get paid to do them. Obviously at DAC, we're very heavily invested in early detection. We're trying to create programs for early detection, and we believe in it wholeheartely. And I would say as a practitioner, when I did early detection and cognitive screening in my practice, the case finding portion of it was, obviously I detected, cognitive impairment and dementia, but a lot of times you don't. But what it does give you the opportunity to do, and what I found in my practice, is it gives you the opportunity to have a conversation with your patient about brain health. And I really developed my skills in discussing brain health when I started doing cognitive screening as part of the Medicare annual wellness visit. And it was a great way to have additional communication with my patients and to talk to them about brain health like I talk to them about cardiovascular or metabolic health.
Kevin, I noticed you were smiling through a couple of your comments there. That's because Dr. Kelleher knows, and so has Dr. Hornbecker, that Voices of Alzheimer's and a number of advocacy organizations are really acutely aware of these challenges and really trying to influence as much as we can the progression of getting these guidelines in place and getting approval, hopefully, from the USPSTF, the United States Preventative Services Task Force, of some new procedures that will move our field forward. So, Kevin, what do you see as the biggest barriers to implementing the tests right now in your mind?
Yeah. First, I'll double down on what Dr. Hornbecker said about brain health, which is, I think everyone who might be watching this understands the idea of, preventing a heart attack or working to prevent their diabetes. I believe we should be having that same discussion on what we do know about ways to modify your risk for dementia of all types, because there's many overlapping risk factors like high cholesterol and your diabetes and prediabetes. And I don't believe primary care doctors are comfortable engaging, having that same discussion about brain health and, avoiding the disease of your brain down the road, which, it isn't a foregone conclusion that you will get dementia. And I think, as was pointed out, the sooner we have some of those discussions, the more we can impact those lifestyle changes that really are impactful, and then arm us with the tool for screening. So now I'll jump on your point. And as you notice, I'm at a standing desk here, like little simple things we can do all day long, just remain active. But again, I think, the obstacles, as you mentioned, or as your question was time. But then the testing, like even right now, literally, one of our patients went to a center around here to be evaluated for that cognitive impairment. And, they sent labs to another place and they got a different set of labs coming in. So right now there's a disparate set of testing one can offer, which hasn't been that validated, that aren't necessarily pulled together. And I think that's the first step is we're seeing studies coming out this year showing, hey, if you combine these certain tests, we're going to improve our accuracy. And so standardizing that, I think, will be very important. The tests that Dr. Hornbecker referred to, combining something called the p-tau along with the beta amyloid ratio, like that is looking as a very unique and, quote, simple blood test when used in conjunction with an interview with their patient and an understanding of their memory and their difficulties might become a very powerful tool. But knowing how to order it, where to order it, understanding that currently it may not be reimbursed by insurance if you're going to recommend it to a patient. So now we're adding a financial cost to somebody who's already a bit worried. So I think that kind of comes back to a guideline or a set standardization of a test package that I can order, just like my cholesterol. I can order a thyroid profile, but the idea of a dementia profile is something that needs to be created and established to make it easier for us.
You know, there's going to be a retroactive impact as well. We have 5 outstanding individuals living with dementia, primarily Alzheimer's, on our board of Voices of Alzheimer's. In the last 3 to 4 months, 2 of those 5, by further testing, they've been living with a diagnosis for 5 or 8 years that was made based on symptoms, to have been living with a diagnosis of Alzheimer's. And because they could now have more, so essentially Medicare is now covering PET scans, they have learned that they don't have Alzheimer's. They do not have elevated amyloid plaque, which is the cornerstone of being able to physically identify the disease. So this is rather shocking to patients who have adjusted their mentality, their life with a diagnosis, and to have that ripped from beneath them. So I think one of the things that's also going to be created is dealing with the emotional impact on people who found that they have been misdiagnosed. Thank you. Moving on. So what now, Kevin, are the biggest barriers? Let's see, I think we've covered that pretty well. Are there particular populations or regions that you think the blood test could have the most impact on in terms of accessibility and diagnostic equity?
And I think perhaps an extension of that is also just when somebody walks in the door, how are we assessing, should I be considering these tests or shouldn't I? And I was thinking about that earlier. You know, family histories are, so family histories of dementia is an important consideration in primary care. Understanding the cumulative risk factors. And so being able to sit down and talk to somebody to understand how many traumatic brain injuries they had in their life. You know, what is their cholesterol, their diabetes. And I think that is all, as I said, I'm excited because that is all slowly being cobbled together in these last, 1 to 3 years. So even us lowly family doctors can get a comprehensive understanding of the cumulative effect of risks over time that allow us to kind of, draw a line in the sand and say, okay, you have had these risks. Some aren't modifiable. Some moving forward are modifiable. Let's do these screening questionnaires. I mentioned we use a platform called Linus that does memory, 3-word recall and clock drawing. Very simple, seemingly simple tests, but are useful screens that can be done quickly. There's more advanced testing. I mentioned the MoCA test, Montreal Cognitive Assessment. So we do have these tools with a little bit of time. And I think to your point, who and how do we decide to use these? It's going to be that gestalt of risk factors, family history, lifestyle, but then to be able to say, hey, I think we now have the opportunity to, take the next step in screening, take the next step with this blood test. There's something called APOE gene, which is, we all get one from our mother, one from our father. There's sort of standard risk with this, but certain gene types will increase your risk for dementia. So Jim, for my practice, I'm looking at those things as reasons to maybe investigate more deeply early on, to consider screening early on based on their risk factors and perhaps their gene profile. And then the ability to add a blood test like this in addition, sort of, I think, helps me to create a more full picture, not only to talk to my patient about, but also then to perhaps hand that off to a neurologist or a specialist in dementia at this point to help me make that final diagnosis, at least until there's an algorithm that allows me to make that conclusive diagnosis. And to maybe a point you're going to make is there was an interesting study out, I think this year, if you estimate the number of aging population and dementia, we currently might have a 5 to 10 month wait to see a specialist. By 2044, the estimate might be 4 to 5 years if we don't change how we look at dementia and how we screen and how we make a decision to treat, which would just be unacceptable. So,
Mike, anything to add on the equitable?
Sure. I think to speak to equity, it's no surprise to anybody who has any knowledge in the space. A lot of the research, a lot of the drug trials with these newer drugs that have been done are overwhelmingly in populations that are high resourced, highly educated, and generally white. So I think it's important for us to expand both our research into traditionally unrepresented populations, African Americans, Asian Americans, things like that. And I think these blood tests have the ability to sort of even the playing field a lot, because any primary care clinic anywhere is used to drawing blood and measuring for cholesterol and things like that, as we said. I think one of the challenges with that is we still don't understand fully how these blood tests might give us some different results in those populations, and also in populations that have higher incidences of comorbid diseases like diabetes, chronic kidney disease, which can affect the results of some of these blood tests as well. And we're starting to understand that, and there's lots of research out there and some good papers about some of those changes. But I think too that the nuances of it are going to be really important to understand as a primary care physician when you're looking to try to make this diagnosis, or at least make it a little bit more clearly and plainly in your own practice, to understand those nuances. So those are some of the things that are still some questions out there that we need to answer. But I think if we can get those answered, these tests could equal the playing field a bit for diagnosis, at least.
So I'm not as discreet as physicians, but one of the things I was taught as I've come lately to this disease is that African Americans develop Alzheimer's at twice the rate of whites, and we didn't understand why. And I'm understanding that through the validation of these blood tests, just as I referred to our board members who did not actually have Alzheimer's and they had thought they had, that many of the African Americans that we thought had Alzheimer's also do not have elevated amyloid. And in fact, they probably don't have Alzheimer's at twice the rate of whites, but they do have dementia. So maybe it's not Alzheimer's, but maybe frontal temporal or other dementias that are more commonly appear with higher blood pressure, with diabetes. And so this is really causing the whole field to be shaken up and rethink what we have taken on symptomatic diagnosis as what the playing field is. So I think that's extremely important as we move forward. Kevin, do you yet have, or either of you, a vision of how blood tests will influence your clinical decision-making? I think we've touched on that. I think, Kevin, you pretty well covered that.
I think that idea of having a process that I know I can go through where that blood test now becomes a valid tool to help me at some inflection point. I do think there is dementia. I don't believe there is dementia. I'm on the fence in talking with my patient, and this test suddenly is now just a standard part of how I'm going to take that next step to understand that person's risks at that moment. And it was alluded to, but Alzheimer's dementia is a evolving process over 20 years plus. And I think that's something really important to understand. Like, you don't wake up and have Alzheimer's and have dementia. This is evolving over a long period of time. And what Dr. Hornbecker was saying about, that early detection of amyloid is really gives us an opportunity to perhaps intervene in the natural process of what the disease has been doing. What we've always assumed was going to continue on its own. The drugs now and the potential drugs in development could truly bend that curve. And that's where I need the tool to make sure I'm intervening and detecting early the presence of amyloid or of early cognitive impairment that is going to be Alzheimer's.
Anything to add to that, Michael?
Sure. I would add actually a little bit to the point that you made, Jim, is that, as we discover some of these misdiagnoses, it makes me also think about the primary care physician. And we also need to have good guidelines as to what they're to do if there's clearly a problem, but these blood tests do not indicate the presence of Alzheimer's disease. So our primary care doctors have to get more comfortable, discussing and diagnosing things like frontotemporal dementia, Lewy body dementia, those kind of things and again, just from our conversation today, it's easy to see how this can be very confusing. And it's often confusing for our specialists. So, I mean, I know Kevin at one point said the lowly family physician, but we're really in the best place to talk to our patients about these things and to help make some of those distinctions once we're equipped with the knowledge and to do so. So I really think that you made a good point there, that it's not just education about Alzheimer's diagnosis, but about all the related dementias that go along with it too.
This is a great amount of information, and I just want you to know how smoothly things are gone. So I flew down here yesterday, and you may think I was a little distracted, but I began this webinar with my red pen, which exploded. So then I switched to my blue pen, and it also exploded based on the air pressure yesterday. So I'm trying to keep my hands down so you don't get alarmed, but I'm not doing very well. So we want to turn to our audience questions, but the one thing that keeps pressing me is, I'm told that it takes 20 years to move from discovery to clinical practice. And Michael, when will we've been hearing about these blood tests for a number of years now, and great promise, everybody's excited about, we've been waiting. I want your promise now. You have to sign on the line here. When will they be available? When will we get them into practice? Can we compress that 20-year historical period which it becomes available to us?
I mean, you're asking sort of the $64,000 question there, if you will, to harken back to the old game shows. But I think it's important to note that some of these assays are available now. And even a few of them are available commercially, and some are even reimbursed. But I think that it's a much, I guess, better way to think of it is when are these going to become standard of care? And I think that is really the $64,000 question. And I wish I could give you a hard, this time next year, Jim, I promise you that they'll be there. But I think the more we have practicing physicians like Kevin and others that are working towards this, and organizations like Voices of Alzheimer's advocating, and DAC that is making that work in some of our projects to bring the understanding of these blood tests better into view, we're going to get there faster. In that 20-year time frame, we can all three agree, and everybody on this call, that's simply unacceptable. But how much we'll shrink it down, I don't know. But I'm very encouraged that the momentum, and I think Kevin alluded to this too, the momentum really seems to be building out there to change the way we're doing things, both diagnosis and treatment of Alzheimer's disease. So I wish I could give you that hard, firm answer. I can't, but we're well on our way.
I'm just a patient, a caregiver, but I can't tell you how much it means to our community to hear from gentlemen like yourself and your commitment, and how hard you are working to make this happen for us, for my children and grandchildren who are at risk because of their genetic makeup. So it is so wonderful to have you so committed to this. So I can't thank you enough. Let me move now. We have 20 minutes left. Kim, do we have any questions in the chat?
Yes, we have two questions here. So our first question is, what are the surrogate markers taken into consideration, and how does that affect the test?
So that's probably directed more at me when I mentioned surrogate markers. When I was talking about the blood tests, what I meant what I meant by that is they don't all directly measure amyloid. So Kevin referred to, you know, the beta amyloid 42 and the 42 to 40 ratio. But we also measure p-tau 217. There are other tau tests as well, but p-tau 217 seems to be the one that has really hit as far as its accuracy. And although we're measuring a different protein, tau, it correlates very closely with the presence of amyloid as well. So that's what I meant by a surrogate marker, not measuring the amyloid directly, but measuring the p-tau level. Does that answer the question?
We'll see if they respond back in the chat, but I think thank you for now. Okay, next question. Someone wrote, I am nearly 79 years old. At my next physical, should I ask for the blood test you described?
I will, I'll give my thoughts on that. So, you know, this assessment shouldn't typically just be a point in time. I think this is something that person who asked the question, if they have a significant other or close family or friends, that's a discussion to have amongst them as well. You know, ask your significant other. There are some online tests, and I believe we are going to post some resources to do sort of self-analysis and to look at maybe some of your own habits or behaviors to see if there is perhaps early indications you might have some memory issues. Again, not all dementia, but so the simple answer is sort of assess where maybe your risk is. If people have been asking you, or if you're concerned about your memory, then 100% you should have that discussion with your primary care doctor about screening, whether or not it's currently covered or there's a guideline for it. That's why you're supposed to have a good relationship with your primary care doctor. Ask about screening. Hopefully it is something like the clock drawing or what's called that MOCA test. Depending on how old the doctor is, they might still be doing something called the mini mental status exam, but start that conversation. And I would honestly say any primary care doctor would want to discuss with you where their understanding is about that blood test and that is it a useful tool. Because it should be a discussion that moves forward. And I think you just bringing it up here on the chat means it's probably something worth bringing up with your primary care doctor. But I do think the link to some of the tools, which are some sort of self-assessments of your lifestyle habits that might predispose or things you can change on your own to further reduce your risk, will also be a tool for you.
Anything to add to that, Dr. Hornbecker?
No, I think Kevin said it pretty well. I mean, these tests are not simple yes or no answers. We don't just get a blood test and that's it. So I think it's a discussion you need to have with your doctor. But as Kevin said, if your doctor is worth his or her salt, they're going to be willing to have that discussion with you and be honest with you about, you know, their comfort level with these blood tests and their understanding of them. Because again, we know that education needs to happen out there, and just because a doc may not know a lot about them doesn't mean they're not willing to learn as time moves, you know, as these things progress.
And you may be the patient that prompts them to do the 3-hour CME to educate themselves, and then you might change their whole practice. So,
amen.
So we have another question from a nurse in the audience, and she asks, what's the role of the nurse to be a navigator in this process? Or do you see a role for the nurse or the medical team?
yeah, I think, and I'm guessing Mike's experience was this too, for a primary care doctor to do their job well, they better be working very closely with their medical team and their nurses. Very often it's the nurse who spends a little bit more time with the patient, might help to assess functioning and memory and recall, might also be a part of even administering some of the tests based on the training within the office. This goes back to 32 years ago in training. I often got more information from the nurses than I did from the physician off the bat. So I think both in navigating the process, depending on how the office runs, but also just the time you spend with the patient. You might have indicators just in your normal daily questioning that might prompt the question. So I think the nurses are vital.
Yeah, I'll tag on to that too. Kevin made a great allusion there to a a good sort of advice to any medical resident out there is be nice to the nurses, because they're going to and they can really make your life hell if you're not nice. However, to get back to that, I think I peeked in the chat, and I think the question also made some reference to a navigator that's sort of parallel to what we see in oncology. That's an interesting topic to raise, and it's very germane to the Davos Alzheimer's Collaborative. So a brain health navigator, if you will, is a project that we're currently undertaking, not my project that I'm leading, but the idea of a navigator to help patients and primary care physicians to navigate the diagnostic process that goes on with Alzheimer's disease is a concept that's out there, and there are institutions that are using it already, and some of that came from the Davos Alzheimer's Collaborative's sort of flagship program, where we worked with places like Indiana University and Advent Health in Florida that had these brain health navigator programs. The interesting thing about oncology is it's all post-diagnosis. So you don't get a navigator until you have a diagnosis, and they help you navigate the treatment phase. And I think that can be important in Alzheimer's disease, because as we know, these treatments are not simple. So having a navigator that is pre-diagnostic, though, because we know the diagnostic process of getting MRIs, getting in to see the neurologist, perhaps a neuropsychological battery of testing. We can order these things in primary care, but then they go sort of off into the ether. And when you have a huge, patient load in the, sometimes 1,500, that was my patient load when I was in primary care. It's really hard to track those things. Are they really getting these things done? And it's not uncommon that people would come back and, yeah, doc, I never got that MRI, or I didn't get into, I had a neurology appointment and, it got canceled because, I didn't have transportation that day, or it snowed or something like that. And so these are real problems with fragmented care, and having a navigator to help navigate that process, knowing that time is of the essence when we're talking about Alzheimer's disease and the new treatments, it could be a very helpful thing. And we're looking at that. It's one of the projects we're looking at DAC.
That's great to hear. Kevin, we've got a few more minutes. I wanted to go back to reversible causes. You really highlighted that to me a year or so ago, and I was astonished. I think there's not definitive research, but it could be as much as 10 to 20% of cognitive impairment may be reversible, or may be caused by things that are not what we think of as dementia. Can you talk about that just a little bit, and what those things are, and why it's so important to identify them, and how lifestyle might impact those things?
Right. Thank you. Yeah. So, as a family doc, that's sort of my bread and butter, is where can we make lifestyle changes that might change the course of disease development, and in particular, what I mentioned: heart attacks, strokes, cancers, and Alzheimer's or other dementias. I think maybe starting at the beginning, where there are throughout our lives risk factors that accumulate, and just educating yourself on what those are. It's the Lancet study that just came out in 2024. Well, it's actually an ongoing commission looking at causes or risk factors, but that stems through things from like how many times you've had a concussion or traumatic brain injury throughout your life. So reducing those risks, there's a lot of 60-year-old, 70-year-old skiers out there. You might want to still reduce your risks of, wear a helmet. But to perhaps the most important things, remaining physically active. There's significant evidence on the feedback that happens from your muscles to your brain by just moving them and resisting them. Factors that we all screen for and maybe don't correlate with dementia, like your LDL cholesterol, clearly a risk factor. And Jim, when you referenced that there's people that have been diagnosed with Alzheimer's, that now as we look, it may not be Alzheimer's. A lot of that might be, micro infarct, like little mini strokes over time, the accumulation of damage from hypertension, from high cholesterol, from diabetes, which damages small blood vessels. And those are major areas for primary care to focus on and for a patient to be aware of, because if you intervene in your 40s and 50s and 60s, we might find we're able to bend the curve or reduce the risk. So exercise, knowing those risk factors of hypertension, cholesterol, diabetes. Of course, I'm sure no one on this call is smoking, because anyone on this call would know better than to smoke, but very important. So then if you're worried that there's cognitive impairment and we're assessing that further, there's an initial just sort of simple evaluations of thyroid function, vitamin deficiencies, in particular B12. There's infectious diseases that can be associated with it. There's also some processes in the brain, something called normal pressure hydrocephaly, where kind of the fluid accumulates pressure in there, and that starts causing cognitive impairments, and that is a treatable condition. And so I think that one of the reasons why people are worried and doctors are worried about even talking about screening is the fear of there isn't something to do. And I just want to really highlight, and I think we've pulled it together well here, not all dementia is Alzheimer's. Alzheimer's, we are looking and growing opportunities to intervene early. And there's a lot of just regular diseases that correlate with just our cognitive function. And the sooner we pay attention to it, the sooner we screen for it, the better we'd all be. So that's my whole spectrum of discussion on it.
Thank you. I'm really glad we could get that in. And I just, in wrapping things up here, I just will turn to Dr. Hornbecker first. Any final comments you'd like to make, Michael?
I think, one, thank you for having us, and thank you to Voices of Alzheimer's for having these conversations and these webinars. These blood-based biomarkers are new and they're exciting. They're going to come to primary care. It's just a matter of how quickly we can get them there so that they're universal and being used. I guess finally, I would say there are still some things to understand. There are still challenges out there, but we should all have hope, and we should be looking at this as good progress forward. But as Kevin said, and I'll echo that, is there's things we can do now and today ourselves to affect our own risk for dementia. So, when we all hang up this call, go out and take a walk, watch your diet, take your statin if your doctor says to, do the things that you're supposed to. And these are things we can all do to have control over our own risk factors for dementia. But yeah, I think that pretty well sums it up. So thank you.
Thank you. Thank you, Michael. Dr. Kelleher.
Yeah. Boy, said like a true family doctor. Thank you. So yes, thank you to Voice of Alzheimer's. I mean, this opportunity to be part of this over this last year has been incredible. I have learned a lot more. I also see where the areas of learning are needed for primary care doctors more and more. But I would just reiterate, my notes to myself about my conclusion here was it is rapidly changing. Encourage your primary care doctor to get more engaged and involved if they aren't. And if they are, you might be the patient that initiates, a next level of understanding or practice change, because we're seeing it. Cognitive impairment and dementia is out there. My take home to everyone is move, exercise of any type, 1 or 2 minute exercise, snacks throughout the day, squats next to your desk, work on strength and stability because we don't want you to fall. And all those common risk factors, remember how they do play a role in your long-term risk: cholesterol, vision, hearing, diabetes, your weight, blood pressure. And these are all things you can talk about with your doctor, and you should, and be proactive and be your best advocate, because we all need that until the system supports it better.
I am sure everyone in the audience understands why we invited these two gentlemen to be our panel today. You guys are just so terrific, so knowledgeable, so committed and compassionate. It's really an honor to have you as our guests. I'd like to repeat a parallel I've heard several times, is that mammograms were developed maybe 40 years ago, and they were something that a specialist administered. And as the technology got cheaper and became more simplified, articles began to appear that encouraged women to request a mammogram. And it's believed that part of the process was speeded because women read how important this was in magazines and came into their annual physicals and asked their doctors for a mammogram. Wouldn't it be great if each of you listening could help move this implementation along by going to your annual physical and asking for a screening? You know, the response may be, wait till next year, let's watch it. You know, that's an avoidance, right? Or, well, the tests aren't here, or I don't have any regulations yet, but we need to start, and Jim Taylor too needs to start pushing back. My physician actually told me, I said, well, what cognitive testing do you do? And he said, well, I listen to how well they remember what their list of medications are, and I compare what they told me a year ago. And if I notice some more hesitancy, then I think there may be a cognitive problem. I said, you're telling me that, and you know what I do? You know, and you know, he was very comfortable with that. So we all have a responsibility, I believe, to help Mike and Kevin in this journey. And let's accept that on ourselves. In addition, we will be sending out to everybody on this webinar some of the resources that Dr. Kelleher mentioned are available for self-assessment, and we'll be putting that on the website as well. But these are very good tools that are being developed that you can take it home on your computer to say, well, maybe there is a cognitive issue you should discuss with your physician, or looks like you're pretty good for your age, which is something that's very important to me given my age. So that's our program today. I hope that in one of the things that Kevin particularly referred to, and Mike, is that there's tremendous breakthrough also in the digital cognitive assessments. So now with artificial intelligence, we're making great progress in being able to administer these screenings or evaluations on a little tablet. And I'd like to pursue that in one of our next webinars to keep you informed, because it's a tremendous amount of change, incredible move forward on many, many fronts. It's hard to stay on top of everything that's happened. So just as a reminder to you, this has been a recorded webinar and will be available to you on our website, voicesofad.com. Revisit it if you wish to hear more information or hear it again. I have to hear it 2 or 3 times in order to remember. And if you want to refer it to somebody else. I just can't thank Kevin and Mike enough. You guys are just wonderful inspirations, and you bring a great deal of hope to us. We appreciate your time and your expertise, and thank you for joining us, and have a great weekend, everyone.
Thank you.
Thank you very much. Bye, everybody.